Yes, spectral photon counting CT. Yes, so thank you, Matthias, for this nice transition. Now I'm really thrilled to show you a glimpse of what spectral photon counting CT will bring to the cardiac field. And at the end, the question will be, is it a game changer or is it not? We'll see. All right. So first of all, thank you, Aurélien. Thank you, Hubert. Thank you, Lyric, and Matthias also and the scientific committee to have invited me here talking about this subject. This is the first time I'm coming in Bordeaux and in Pessac and in IHU, and clearly I have missed a lot not coming here. So it's really nice, and we have a really nice place. And also, just a quick comment on the team from Lausanne. It's a great pleasure to see you again. I left for surgery reason, or anyway, for just an uncle, and my uncle is going well now, and I did not have the time to say goodbye, or anyway. So clearly, it's a tribute, or let's say, let's move on to a cardiac spectral photon counting CT. So I have 15 minutes. I can talk about 2 days, 1 week, so I will just chronometer. Okay. So CT, computed tomography, is, everybody knows, even Matthias, it is an excellent modality for cardiac and coronary imaging. It can catch in a few seconds the coronary arteries and the cardiac muscle. And as a matter of fact, it's currently a great modality, imaging modality, for having great information, diagnostic information, screening information, predictive information, and image-guided therapy information, for example, for, of course, the coronary artery disease, but also all the cardiac disease, and more computed tomography is needed for the management of cardiac patients. But clearly, we are at the beginning of CT. Why? Because current CT is deeply limited by its structure, its detectors. Clearly, it's like an iPhone from the 0 to the 14 iPhone. I would say that there was a huge development due to the technology. And clearly, the current technology of computed tomography is frustrating. And I feel now why Matthias is saying that it's boring, because this detector is boring. Why? It is too large. The surface is too large because of architecture. Why also? Because there is this setup between each pixel detector that will limit the spatial resolution. And why also? Because it's only performing an indirect conversion of the X-ray photons into electronic signal using first conversion in visible light and then photodiode to convert into electronic signal. And this is frustrating because it limits the spatial resolution to 800 microns. It limits the contrast resolution in terms of visualizing the early or late enhancement in the myocardium. It is limiting also the strategy to decrease the X-ray dose, and it's also limiting the absolute quantification and the capability of specific imaging. So to overcome this frustration, there is this new detectors called the photon counting detectors that is an energy resolving detectors. Basically what it's doing, it's converting directly the X-ray photons into an electronic charge. There is no indirect conversion, which will lead to the resolving of the energies of each photons. You have to know that 1 million per millimeter per seconds photons are hitting the pixel detectors. That is meaning that these detectors have to be sufficient or efficient to convert each photons into a specific information will be an energy. The second aspect of this architecture is that these pixels are much smaller than the energy integrating detectors. And this will enables ultra high resolution around 250 microns, which is 2 or 3 times more important than the standard CT. One more aspect, and there are many aspects, but one important aspect is that you will decrease, you will improve the dose efficiency in terms of signal. That will be important to increase the contrast resolution, but also important to also decrease the X-ray dose you need to provide a diagnostic quality enough for the patients and for the myocardium. So altogether, based on this architecture and technical benefits, we can expect from in cardiac imaging an image quality improvement, a diagnostic quality, a diagnostic confidence, and a reduction in X-ray dose. But the real question is it going to be a game changer in terms of imaging? So we will see, I will show you a glimpse of data that are providing evidence for this change. First of all, let's start with the beginning, screening the patient, screening the cardiovascular risk of a patient. Everybody knows that it can be currently done by assessing the cardiovascular risk, Framingham score, for example, but there is one biomarker in imaging, which is the Agathon score, which is really important in terms of evaluation and with a strong predictive value. And this Agathon score, unfortunately, is still imprecise, inaccurate because of the limitation of conventional CT. And this is where photocounting can also improve in two ways. First, it can decrease the Agathon score and decrease the cardiovascular risk of a patient by decreasing the blooming artifact around the calcification. One can see here on the left and bottom side a calcification assessed by conventional CT that is that will provide a volume, lower volume with photocounting CT in comparison, and which will be more accurate in comparison to micro CT. And this can change, reclassify the patient from the high risk to the lower risk. The second aspect, it can also classify the patient from low risk to higher risk. And you see that in terms of detection, it will improve the detection of low dense calcification and small calcification. And this can be a really important aspect of screening the patients. In terms of, here it's an example of a patient, a 60-year-old patient with a coronary CTA, and one can see that two spotty calcification can be depicted in comparison to conventional CT. So there is evidence of change in terms of screening the patient cardiovascular risk assessment. Now, in terms of diagnosis, the coronary artery imaging. First of all, by improving the spatial resolution, it can clearly bring some more information in terms of micro circulation or small distal vessels. This is the case of septal branch arteries here on photocounting CT in comparison here on photocounting CT comparison to conventional CT, where the black arrows are depicting some vessels that cannot be assessed with conventional CT. And this is important, particularly also for the high-risk cardiovascular patients that currently are not a good candidate for conventional CT. And this is written black and white in the European Society Cardiology guidelines that CT is not appropriate for this type of population. With photocounting, spectral photocounting CT, it can be used and showing a high specificity in comparison of the specificity we know for conventional CT. Currently, having a patient with a high calcified burden, the specificity is dropping to 50 to 55%. In our experience, the work performed by Guillaume, a radiologist from CHUV that is performing a research fellow, he showed that the specificity is rising up to 90% in terms of accuracy of coronary stenosis quantification. That will maybe strong evidence to provide and to assess the coronary artery disease using photocounting CT in high-risk cardiovascular patients. And as a matter of fact, this is an example of a patient that went in a hospital for chest pain. He had two stents back in the days, and in that stent, you will see that there is a very important complication, which is the involvement of hyperplasia, neointimal hyperplasia, that is a well-known complication of the stent, and that can lead to a thrombus involvement, and at the end that can lead us to a myocardial infarction, which was the case for this patient. But this case is important because in comparison to a method of reference such as invasive coronary angiography or optical coherence tomography imaging, spectral photocounting CT in comparison to conventional CT is providing a comprehensive assessment of the stents and the lumen. And this is really important in terms of management of this patient, because there is no need to go into the invasive coronary angiography, which can be at risk for this patient. He has a stent with unstable thrombus, unstable stent, and so spectral photocounting CT will provide what we need to know for this patient. First of all, we need to assess that there is a displacement of the stent due to a peripheral outborder calcification, but also we need to know and to assess the involvement of the low dense part in the lumen, which is hyperplasia neointimal, and also thrombus. And this for the patient, it is important because we will follow this patient not with coronary angiography that can be at risk of dissection, of even more thrombus displacement, but also, it's really important to avoid unnecessary and risky invasive coronary angiogram. And it's also important because it's showing, in comparison to this OCT imaging, similarly results which cannot be unthinkable, which is unthinkable using conventional CT. Laurelien told me, and Pauline told me, you have to speak about also brain or neurology. So I will show you, I'm not an expert on that field, but I mean, coronary arteries is also the same than carotid vessels or brain vessels. So I will show you a really important study. We have a prospective study on carotid plaque imaging. And this is interesting because for those that knows conventional CT in carotid plaque imaging, you will see always a strong blooming artifact arising from calcification. Conversely to this, you have, with this technique, you have a very understanding of the complexity of calcification from intima to the media, and this is a really interesting aspect, even more when it concerns a powder of microcalcification that we know that can be start at the beginning of atherosclerosis due to osteogenesis. So it's really interesting to see that not only you can assess the complexity of calcification, but also you can assess a very small diameter of the lumen, which here has been quantified around 500 microns. And this could be also the interest for other small or narrow stenosis, that this vertebral artery between the bones, which is usually unthinkable using conventional CT. It's not also the neck vessels, of course, it could be also used in the brain. And this is a case from Professor Omer-Eker that it was a really complicated case. As a matter of fact, he treated this patient for different aneurysm with the coils, and also there was some surgical treatment. And the challenge here was to see if we can decrease the artifact from these coils by improving the spatial resolution, and be able to see if the vessels were patent, which was patent. So this was the case. So it is where spectral photocounting CT can change the game in terms of brain or carotid vessel imaging, including plaque also for, of course, coronary artery disease. And this is really important for this patient who was suffering from myocardial infarction, non-obstructive coronary artery disease, MINOCA. This patient, she went to a hospital, and for MINOCA, she did have a coronary angiogram that was negative, and went and performed the conventional CT that was showing a low dense plaque with unsatisfactory diagnostic quality, which is not the case with photocounting CT, where we clearly determine the burden of this plaque that is highly vulnerable. I was talking about coronary artery disease, but I can talk about also cardiac muscle to improve the sensitivity of myocardial ischemia, but also to improve the conspicuity of all the cardiac structure. And this is important. This is not a non-compaction of the left ventricle. This is just a secondary dilated cardiopathy where you can clearly see the trabeculation, even false tendon in the cavity, with a clear and a very bright diagnostic quality. For the last minute, I will say that I was showing incremental findings, and now, for the last minute, I would just show the groundbreaking spectral benefits of this technology, and this is clearly some things that will bring to the next 10 or 20 years, because we need to develop new contrast agents to provide the specific imaging brought by these energy-resolving detectors that will allow to show the morphological and the functional aspect of an organ perfusion, myocardium, lung, and other organs, to also bring the morphological to the functional assessment of inflammation, for example, in the plaque, atherosclerotic plaque, confirmed here by several in-depth histology and gold standard methods, and also to show if there is a possibility to improve and to provide MRI-like analysis of the myocardial damage, such as here in ischemia. So for all this evidence and for the versatility of spectral photocounting CT to overcome the limitation of conventional CT and to expand the field of this technology to the cardiac imaging, I think that it might be a good candidate for changing the game in cardiac imaging. And I hope you will be a little bit convinced. And that's why thank you for your attention, and be really glad to answer to your questions.
Do I need a mic? No. All right. So you spent the entire presentation on coronary imaging and one slide on the myocardium and on KH imaging. So in your opinion, I agree with you, this could be the transformative CT, and this is where it could potentially be. The question is, which contrast agents will we be able to reach sufficient concentration? Using KH, what do you anticipate to be the most probable clinically applicable element?
So we have a very large possibility for developing these KH contrast agents, and this is interesting to have on board the biochemist. I should have somebody here on my right side to say, okay, I have this element, I have this one, I have this one, I have this one. And as a matter of fact, we have a lot of possibilities of biochemists. And the biochemists, they don't know the clinical application, and I don't know how to make their contrast agent. So what I'm trying to say is that we have to get close to this community, and being close now as a researcher to this community, I see that there are many possibilities from different concentration, from low to high, from different atoms to rise up the sensitivity, because this is an interaction between the photons, the energy of the photons, the current tube, the tube voltage, and the proper energy of each element, and also change in terms of structure, in terms of also at the end, ultimate goal. And this is also interesting because we can think about diagnostic, from diagnostic to theranostic, and this might be also interesting in terms of clinical application. So clearly there is a large community and large possibility in terms of boosting the sensitivity. We are talking about gadolinium, but gadolinium is not the key. We have many. We have published, for example, evidence that tantalum and ytterbium can be the best element to provide KH, which will be clearly improving the sensitivity and lowering the final concentration of the compounds. So we are at the beginning, and there are many developments to do, and I'm sure we will find out something interesting, and we can then target or non-target the contrast agents to specific imaging, to the myocardium, ischemia, also to maybe to a theranostic approach.
How does it compare to PET in terms of sensitivity?
It's not the same. Of course. There is no competition. I mean, this is 6 to 10 times less sensitivity than PET. So clearly, it's not the case. But PET is struggling with, I mean, everybody wants to do CT. Yeah.
Okay, we understand. Thank you very much.